Next, we move to Dario, and next we're talking is common arterial trunk. And then after that, we are into double outlet right ventricle.
So, good morning again. Now we're moving into the abnormal pathologies, and this is again for malalignment VSD. And as for last slide by Simon, you see here also from China a case of unrepaired troncos in an adult, and you see nicely the anatomy on this image. So the troncos is one of the several abnormalities of the ConoTruncales, which we will deal with over the next few hours. And I highlighted among them also the pulmonary atresia with VSD that Simon brilliantly showed to you right now, because that's the most important and most relevant and challenging sometimes differential diagnosis for the common arterial trunk. So if we go to anatomy, what is a primary lesion made of? There are a few features. You have a malaligned VSD, which is common to several of the ConoTruncale malformation with an overriding aorta. And you should consider that when you have a single outlet from the two ventricles, then the whole of the blood gets into this single outlet. And this is why the size of the single outlet is larger than normal. Okay, so you have a very large single vessel rising across the two ventricles. And then you may have, you do not have, of course, any connection between the right ventricle and pulmonary trunk as such. You may have this plastic truncal valve because it derives from the missed separation of the cells making up the two semilunar valves in the normal heart. And often, as I'll show you, one particular feature of the common arterial trunk is that it's looking towards mainly the right ventricle. Okay? You may have associated abnormalities, mainly of the aortic arch, but also other major abnormalities in the context of cardiac splenic syndromes as well. A typical feature of all ConoTruncale malformation, and also for other abnormalities of the fetal heart, is that they represent a stop in the single clip of the development of the normal fetal heart. So in any phase of the cardiac development, if that particular process is stopped, is halted, that results in a single anomaly. And this is quite true for the common arterial trunk and ConoTruncale malformation in general. In fact, if you look at the normal embryonic evidence of the bulbous and the conus here, which starts to be separated into the two outflows, that's exactly the same anatomy that you have in common arterial trunk. What happens in the normal heart while it develops, you have three components of the septum, which goes from the top towards the inflow and not the other way around, as in this GIF that you see here. And these grow also spiraling into the single outflow. And the two features that are more relevant are that the first two components of the septum are made by migrated neural cells, okay? And this is a nice of a chicken, a nice transmission electron microscope image of the two cushion of neural cells that are going to fuse on the midline and separate eventually the pulmonary trunk in the front from the aortic trunk in the back. And at the same time, the third component of the septum is made up from cells of the original pharyngeal arches 4 and 6. And if any of these phase of the cardiac development fails, you have a common arterial trunk. And another issue that explains you the significant relationship with the microdeletion 22q1 is the fact that both these population of cells are arrested in their migration in case of this kind of microdeletion. And this is the key element that links the microdeletion to this type of cardiac abnormalities. Coming back to the anatomy, you have, as for most congenital heart defects, you have a classification because you have subset of malformations. And the most common classification used is this, which dates back to the 50s of the last century, And you have actually three types of truncus. You have the type 1, in which you have the main pulmonary trunk arising from the aorta, from the truncus just above the truncal valve here, and then it separates into the two branches. And type 2 and 3, in which you do not have the main trunk, you have directly the two branches, which arises the same distance from the truncal valve in type 2, or at different distance from truncal valve in type 3. And the challenging fact that explains you why it's so difficult to pick up these tiny branches while doing your fetal echo is that you see that they arise mainly from the posterior aspect of the trunk. So it's more difficult to find them. Let's see some imaging. So first of all, a malalignment VSD with overriding large aorta. And you see here, this is the part that you're looking at. And again, here is the clip. You see a very nice prevalent vessel here, and you see the pulmonary trunk arising here. Sometimes, as I'll tell you in a while, you have this kind of straddling over the right ventricle, in which you see that the truncus is mainly oriented towards the anterior ventricle. And this is the corresponding image that you see here. And this is a case in which this straddling was even more pronounced, in which the truncus was directly looking into the right ventricle and was a very, very limited evidence of the malalignment VSD, which was anyway there. Then, once you've seen the malalignment VSD with the overriding aorta, you should turn your attention and focus on the pulmonary artery circulation anatomy. So check if you see a vessel, then bifurcates, and this is consistent with truncus type 1. Or if you have a very, very tiny branch just above the valve, you do not see the other one, but still is quite challenging. So this may be both type 2 and or type 3, according to at what height distance from the valve you will have the second branch of the pulmonary circulation. As you can see in this image, you may have very different sides of the pulmonary artery in the context of common arterial trunk. And you see here that there was a type 1 with an hypoplastic pulmonary trunk. You have another type 1 in which the sides of the pulmonary trunk was decent. And then you have, if you have a condition in which the pulmonary trunk, in this case is lower than the other one, is larger or same size as the aorta, then you should think that it's an indication that you may have, in addition to the truncus, also an obstruction of the aortic arch, either partial as for coarctation or complete as interruption of the aortic arch. Why I told you before that there is a challenging differential diagnosis versus PA-VSD? Because several of the features that are there, and you look at the squares here, are quite similar in the two conditions. You have a malalignment VSD in both. You have an overriding aorta, which is large because in both conditions it represents the single outflow from the heart, and you have an absent connection between the right ventricle and the right artery. Okay, so this is in common, and this is why between the common arterial trunk that you see here and the PA-VSD, which is shown here, the anatomy is quite similar, because you look here, you still have a malalignment, you have a large vessel here, you have a hint of a vessel which might be connecting with the truncus and then becomes a truncus, or it might not be connecting just behind it, but it's so hypoplastic it's difficult to trace it out, and in this case it represents a PA-VSD. Okay? And the situation is even more difficult and challenging because, as some of you may know, also in the context of PA-VSD, the anatomy of the pulmonary artery and branches may vary significantly. So you may have some cases which are called extreme tetralogy of Fallot, in which you do have a pulmonary trunk and you have the branches here, but you have atresia of the pulmonary semilunar valve. In other cases, you have only the confluent branches here that are irrorated by the ductus arteriosus, but there is no evidence of the trunk at all. And you can understand easily that this type of anatomy is quite similar to that you see in common arterial trunk. But you have some different, tiny, subtle, and inconstant differential hints that may lead you to favor one diagnosis or close one diagnosis versus the other. The first one is the fact that in pulmonary atresia plus VSD, the cells that will make up the two different semilunar valves do migrate, even though the development of the pulmonary one is arrested. So you do not have an excess of cells on the aortic valve. On the other side, in the common arterial trunk, these cells do not migrate at all. So the truncal valve is by definition dysplastic. Maybe clinically relevant because you have severe insufficiency, as I'll show you in a while, or maybe clinical less relevant, but you, by definition, anatomy-wise, you do have dysplastic truncal valve in any case. And you see here, in this case, this is the same clip I showed you before. If you look at the anatomy of the truncal valve, is severely thickened, hyperechoic, and coaptation of the valves of the leaflets is not so, of the cusps, sorry, is not so normal, and this is consistent with severe insufficiency and dysplastic changes. Whereas in pulmonary atresia plus VSD, as you see, the trunk, the valve of the aorta looks actually unremarkable in most cases. Another feature that you may find also in PAVSD, which tells you the diagnosis, is the association with so-called MAPCAS, which stands for main aortopulmonary collateral arteries. And you see from these drawings that I put here, we don't have time to expand into this, but you may have several of these. Together with the normal pulmonary circulation, meaning the two confluent branches from the ductus, or not. And you see this clip, clip was done scrolling up and down the heart from the four-chamber view, and you see here one pulmonary vein and one MAPCA arising from the aorta. Then I go down, up again, the same MAPCA as before here, another one coming out here. These are abnormal vessels, should not be there. Then I'm reaching the ductus, and this is one pulmonary branch, and I cannot see the other one, reaching up in the upper mediastinum to the thigh box, showing the two internal mammary artery, and there was also a small thymus going back, and again, the right pulmonary branch here, and no left pulmonary branch, and two MAPCAs here. Another way to look at MAPCAs, if you have a favorable fetal position, is to get a ventral view of the aortic arch, and in this case, if you see a vessel arising from the ventral aspect of the descending aorta, this level just behind the heart, this is not a normal vessel, but in the context of PAVSD is evidence of a MAPCA. What about 3D? Can 3D tell us something more about the actual classification of the truncus? Well, it may not. Probably these days with the new high-frequency high-resolution transducer is not so helpful, and especially considering that the best ever reproduction of 3D casts of the outflow tract was obtained with the so-called B-flow technology, which was blocked and not invested anymore in development of this technology over the latest release of this scanner. So you see here, these are rather old images, but you see a type 2, in which the two branches are arising at the same distance from the truncal valve, which is here, okay? And this is a type 3 seen from the posterior aspect of the heart. So this is a malalignment VSD. This is one branch, and this is the other branch on the top. So this is type 3. Nowadays, what we are left with to reproduce this cast is the HD flow, or high definition, high resolution power Doppler, which is helpful, is nice to see, as you see here from these three examples, but doesn't help us so much as we had the impression that the B-flow was helping us in the past. What about the prognosis? There are few features that should be looked at. The first one is the functional status of the truncal valve. You see here a case in which the truncal valve is perfectly normal. From the clinical standpoint, of course, as I told you, it is dysplastic, but is not associated with major insufficiency. And this other case, you see thickened cusps here and the corresponding color Doppler. You would expect this huge insufficiency of the truncal valve, and to a less extent, also a stenotic component. You see turbulent flow and aliasing also on the systolic part of the cardiac cycle. The second feature that you should look at is whether there is a second or even a third major cardiac anomaly associated. And the hint towards that, as I told you before, is the presence of a prevalent pulmonary artery versus the sides of the truncus. So in this case, it's the normal, among commas, sides of the pulmonary trunk, which is slightly smaller than the truncus. So in this case, you would not expect interruption of the aortic arch, whereas in these other two cases, you see here, the sides of the two vessels are quite alike, especially in this case here, in which actually you cannot tell if you do not see the bifurcation of the pulmonary trunk and you do not see the direction of the vessel, which is what, whether it is a pulmonary artery here or here. So in this case, go to the upper mediastinum and check for the aortic arch, because you will find interruption of the aortic arch in most of the cases. And the third element that I'm coming back to the genetics is to look at the upper mediastinum for evidence of thymus hypoplasia or aplasia. And what we use, you may be aware that I described it several years ago as the Thai box, because I was using the depiction of the internal mammary artery to look at the thymic area here. And Rabi published a paper in which you can objectivate your data and your measurement by doing the ratio between the actual sides of including up to the major vessel here from the sternum. And these are two cases at 20 weeks of gestation. In this case, there was a normal thymus, and you see here that there was a significant distance from the single vessel here to the sternal plate. And in this case, there was no thymus at all, because the vessels were just behind the sternal plate. And this is corresponding to the image of this case here, in which the thymus was virtually absent. And it was confirmed as a microdeletion 22q11. So as far as the prognosis is concerned in the fetus, you have to look at cardiac features. First one, if there is a significant insufficiency, steno insufficiency of the truncal valve. Second, if there is an association with major other congenital defects, mainly aortic arch anomalies, and also extracardiac anomalies, because you have a significant association. One of three truncus are associated with microdeletion 22q11. Abnormal karyotype is decreasing thanks to the introduction of cell-free DNA screening, and also a significant amount of extracardiac anomalies related to these two abnormalities. As far as the survival is concerned, these are the three main features that will impact on survival. If you do not have them at birth, then survival rates with correction exceeds 90% to 10 years in most of the cases, in most of the series. If you do have any or more of these features, it drops to below 60%. I will not get into further details about that, because it's a matter of discussion. It also relates to pediatric cardiologists and cardiac surgeons. So in conclusion, for the truncus, this can be adequately characterized in utero. In this condition, as well as the variants of the tetralogy of Fallot that Simon spoke about before, the risk of association with microdeletion is extreme, in the range of 30 to 40%, whereas the risk of aneuploidy, which is there epidemiologically, is decreasing, because you will eliminate by termination these fetuses earlier in pregnancy, thanks to introduction of cell-free DNA testing. As a result, if you decrease the incidence of one condition, you increase relatively the incidence of the other condition, and that's in keeping with the rabbit's talk before on rare genetic conditions. And remember, anytime you see not only troncales but all ConoTruncale malformations, to go to the upper mediastinum, look for the size of the thymus and additional extracardiac features, the kidney, polyhydramnios, and the face, as Rabbi showed you before, because this may be a sign of microdeletion 22 crown 1. And as we were telling you in the discussion before, always go for CGHRA, and we are pushing all of us towards exome sequencing in most of these cases, if not in all, as I put in this button. And let me finish with the invitation to you, either remotely or on-site to Genoa, to my ISUOG course in November. You have flyers outside. You have a QR code, and you can look at the detailed program, and you're welcome in autumn to Genoa. Thank you so much for your attention.
Thanks, Dario, for that talk. And you can see that there's quite a crossover between Tétrada de Fallot and pulmonary atresia and common arterial trunk. And when it comes to question time, we might address exactly that question: is how important is it to distinguish between the two from the surgical management point of view? So thanks, Dario, for a fantastic talk.